Respected Chairperson and dear participants, Assalamu alaikum. I am going to start my presentation with two cases. This is the story of a 55-year-old lady with hypertension and psoriasis who got admitted 2 years back with dyspnea of 3 days duration, and ultimately she was diagnosed with a case of ischemic cardiomyopathy with reduced ejection fraction of 28%. And for further evaluation, she was admitted in another prestigious hospital in Dhaka, and there the same diagnosis was echoed, and the ejection fraction was to some extent better, 48%. And the next month, she attended a private chamber, and where the diagnosis of interventricular conduction delay with ventricular extrasystoles were made, and ultimately the diagnosis was hypertension, and the suspicion was this might be a case of tachycardia-induced cardiomyopathy. And after 2 years, the lady had repeated syncope, last time that leads to a head injury. And other parameters were normal, and MRI of the brain was also unremarkable. And this was the ECG of the lady. Just you are seeing that this was a case of trifascicular block. Ultimately, Holter monitoring was done, and we are seeing that there was atrial flutter with high-grade AV block, and also there are some sinus pauses, and this beautifully explains the presence of syncope in this lady. And the situation was really very urgent, and this was the echo of the lady, and we are seeing that there was concentric hypertrophy of the left ventricle with reduced kinetics. And if you just look at the echo, there was granular appearance of the myocardium. The leaflets of the valves were thickened. The right ventricle was also thickened, and there was certainly biatrial enlargement. The lady was having restrictive type of diastolic dysfunction. And on the right side, just look at the right side, this was the apical sparing pattern in the strain rate imaging of the left ventricle. So the presumptive diagnosis of that lady might have cardiac amyloidosis, and coronary angiogram was normal. The situation was so volatile that cardiac magnetic resonance could not be done. Then she was just managed with AICD at a private hospital, and within 1 month, the lady succumbed. This is the story of the second case. This is another middle-aged man without any hypertension who attended an internist who made the diagnosis of congestive cardiac failure, and the echo done at that time revealed concentric left ventricular hypertrophy with preserved left ventricular systolic function. Other parameters were normal. This was the ECG. There might be old myocardial infarction inferior along with some ST segment elevation in the precordial leads. Echo revealed, I must appreciate the endeavor of the cardiologist at a periphery in Bangladesh. He just suspected, he had the suspicion of cardiac amyloidosis with mildly reduced LV systolic function with advanced diastolic dysfunction. The patient was referred to Dhaka. This was the echo of the second person, the same findings as like the previous one, just we are seeing. The same granular appearance, and despite left ventricular hypertrophy, the ejection fraction was around 40%, along with the reduced right ventricular systolic function. This second person was also having advanced diastolic dysfunction. And just look at the interatrial septum. The interatrial septum was characteristically thickened. And whenever the left ventricular GLS was concerned, the polar map beautifully revealed the apical sparing pattern, another literary term of which is cherry on top appearance. Again, for this patient, the coronary angiogram was normal. Further investigation done by a hematologist revealed absence of Benzone's protein in urine. Plasma protein electrophoresis was normal, but the light chain ratio was grossly altered. And the tongue biopsy revealed that just apple green birefringence under the polarizing light. And this was done in Dhaka. So in this case, from the internist to hematologist, this was a journey of 1 month, quite satisfactory for the perspective of Bangladesh. Now, a few words regarding the basics of amyloidosis. Amyloids are actually insoluble fibrillary proteins deposited in the interstitium, leading to organ dysfunction. There are a number of amyloids. But for the heart, we the cardiologists, two are mainly important. One is light chain amyloidosis, and another one is transthyretin-related amyloidosis. The light chain amyloidosis is very closely related to plasma cell dyscrasia, and in case of ATTR, this is related to the transthyretin, which is a thyroxine-binding protein. But these two types cannot be distinguished morphologically. Then when to suspect? There are some features by which we can suspect if the patient presents with heart failure with reduced ejection fraction, orthostatic hypotension, peripheral neuropathy, bilateral carpal tunnel syndrome, and proteinuria, if the ECG shows low voltage, and if there is unexplained LVH with apical sparing, and if there is biomarkers raised like troponin elevation and the natriuretic peptide elevation persistently, we can suspect. This is a very important dictum that if you are in your practical life, you are dealing with a patient with gross left ventricular hypertrophy, but the ECG is characteristically low voltage, you should exclude cardiac amyloidosis. And look at this, I am not going into detail. Just this is a beautiful modality of echocardiography by means of just strain rate imaging. And in case of normal heart, the left one is the characteristic. And for the athlete's heart, this is the one, this is the hypertrophic cardiomyopathy, and this is the apical variety of hypertrophic cardiomyopathy, and this is the very cardiac amyloidosis case, which is today's topic. This is the cherry red, just cherry on top appearance, and this has got quite good 93% sensitivity and 82% specificity for the diagnosis of cardiac amyloidosis. What to do whenever we are suspecting cardiac amyloidosis? At first, we have to think of AL type of amyloidosis. And for this reason, two investigations are the initial investigations of choice. One is serum free light chain ratio. I am telling about kappa lambda ratio. And another one is immunofixation electrophoresis of serum and urine. And these tests are luckily available in Dhaka, but not so widely available. You can do the tests at the lowest cost in the National Institute of Laboratory Medicine and Referral Center, which is situated in Agargaon. It can also be done AFIP, Evercare Hospital, and some private centers like SRL Lab. But this thing is not so simple for the ATTR type. For the exclusion of ATTR type of amyloidosis, after exclusion of the AL type of amyloidosis, you can do this by means of radioactive technetium-labeled bone scintigraphy, which is not routinely done in Bangladesh, but probably can be done in the National Institute of Nuclear Medicine, which is situated in different parts of Bangladesh. For further testing, histopathology, bone marrow biopsy, and mass spectrometry and genetic testing may be needed. What is the global scenario? Myocardial diseases are overall neglected and the diagnosis is often delayed. Even in the Western countries, there may be up to 36 months from the beginning to the diagnosis of the cardiac amyloidosis. What is the Bangladesh perspective? High degree of suspicion is lacking and high quality of echo availability is very limited. SRI, that is strain rate imaging, is often underused. Other tests suffer from limited availability like light chain ratio, immunofixation electrophoresis, Congo red staining, cardiac magnetic resonance is still in infancy, and the technetium-labeled bone scintigraphy virtually not done in Bangladesh. Endomyocardial biopsy infrequently practiced, if at all, and the mass spectrometry is not available in Bangladesh to the best of my knowledge. And the most important thing is that team approach for the diagnosis of cardiac amyloidosis is lacking. What I am going to say that this is the high time to not only diagnose with the left ventricular hypertrophy, rather we should think of the rarer cases of left ventricular hypertrophy. Then we can save the patients because there are some emerging treatments that can help these groups of unreached patients. Thank you all for patient hearing.